Hi everyone, how are you? It's Dr. Splichal, functional podiatrist, human movement specialist, and founder of EBFA Global and Neuromas. So today we are speaking about neuromas and neuroma pain. So a neuroma is a intercrossing or a scarring, a nerve bundle of the nerves in the bottom of the foot. Now, typically, people will think of a neuroma as just a Morton's neuroma. So they will consider any neuroma to be a Morton's neuroma. A Morton's neuroma is very specific to a nerve injury in the third inner space. So it's going to create symptoms and a triggering of pain or numbness through the third and fourth digit or the third and fourth metatarsal. That is a classic Morton's neuroma. This is the most common location for a neuroma, and this is because of the unique formation and crossing of the plantar nerves in the bottom of the foot. Technically, the medial and the lateral plantar nerves cross right in that area, which is why, again, this is the most prevalent or the most common neuroma where you will find them. However, you can find neuromas in all the inner spaces. So you could have them between the first and the second and the third, and then of course the fourth and the fifth. They do not have the name Morton's neuroma. They would just be referred to as an intermetatarsal neuroma. Now, the symptoms of a neuroma of this scarred nerve bundle is going to be possibly pain, and typically that pain presents as a sharp stabbing pain as you shift forward and you're about to take a step. So when you get into the lever position of the foot, which is if you do a calf raise, you can look at your foot, that's a lever position. That forward progression of the foot puts pressure and compression against that scarred and irritated nerve bundle. Now, outside of pain, sometimes patients will say that they get numbness into the third, fourth, second, whatever digits are in association with that neuroma. And typically the numbness is actually in the side or that inner lining of the digit. And that just has to do with the way that the digit nerves run. So there would be numbness along the inside of the digits. Sometimes patients will say that they feel like they're stepping in a wrinkle of their sock, or that they're stepping on a pea or a pebble, that they feel like there's something in their shoe. They'll take their shoe off, kind of shake it out. There's nothing in there. They put their shoe on, and again, they have that sensation. So that's kind of a neuroma sensation. So sometimes pain, sometimes numbness, sometimes it'll just feel again like a pebble or a wrinkle in the sock. Now, some of the common causes of neuromas is going to be anything that restricts the natural splaying or spreading of the metatarsals. Now, as we shift forward into the lever position, or we shift forward on the foot to take a step, what happens is your foot actually spreads. This metatarsal spreading or splaying is how you trigger stability of the foot. Now, if you cannot splay and spread the forefoot as you shift forward, you technically can start to compress, pinch that nerve tissue, which then creates a irritation response, inflammation, scarring, fibrosis, things like that happen in other itises in the body. Now, what also happens is that all of the muscles in the foot are organized in compartments with this beautiful fascial organization. And if you don't stabilize your foot fast enough, because you can't get splay, you can actually rub some of the sharp borders of this fascia against the nerve, and that also can cause a neuroma. So it's not just simply you're pushing and compressing the nerve, meaning if you wear narrow shoes, you just compress it. That's part of it, but it is a little bit more complex than that. So now when we're thinking about how do we address this, how do we start to reduce the symptoms and the causes of these neuromas in the first place? You gotta support foot splay. So yes, that means get into wider toe box shoes, more of a minimal shoe, but you also wanna use different paddings that support this. One of my favorite paddings for the foot is called a metatarsal pad. And that metatarsal pad you would place on the ball of the foot foot or just short of the ball of the foot, and it's going to pop those metatarsals open and splay, reinforce splay of the metatarsals as you shift forward. So metatarsal pad, wider toe box shoe. Because this is a scarred nerve tissue, there is a fascial component to it. So you do want to make sure that you're getting in there and you're doing some soft tissue release. If you're familiar with the neural ball from Neboso, if you open it up, there's actually a little rad roller micro inside it, which is great to get in between those metatarsals, definitely release. I definitely go towards toe spacers. So opening up those metatarsals, those digits, the small muscles in the fascia of the forefoot with a toe spacer. And then oftentimes I will actually recommend injections. So if you have a neuroma, one of your patients or clients has a neuroma, you can just start by doing wider shoes, metatarsal pad, toe spacers, and then SMR or releasing to the small muscles and tissue of the foot. You could do that for a while. However, if their neuroma is very symptomatic and every step they take, they're getting this sharp pain, this 10 out of 10 sharp stabbing pain in the foot, you may want to consider an injection. Now, the injection would be initially a steroid, whether that is dexamethasone or some sort of corticosteroid to decrease the inflammation that's sitting around that neuroma. Oftentimes in neuromas, you get what's called peri-inflammation. So the nerve tissue itself may not be inflamed, but there's inflammation around all of the connective tissue around it. The steroid injection would address any of that inflammation. Now, in many patients, that's all it takes, and they get great relief from that. However, for some patients, you do the steroid injection and it's not preventing or it's not reducing any of their symptoms, which means I then go towards another type of injection, which is an alcohol injection. The alcohol injections, you actually would do a series of them. You could do, average that I'll do for patients is 6 to 10, and usually I will get a sufficient response at that point, but you would do one injection every week consecutively 6 to 10 weeks. And what that alcohol does is it's slowly sclerosing or shrinking the size of the neuroma. Again, what could be the issue with the neuroma and the symptoms that you're having yourself, your patients, your clients, is not just this nerve bundle is inflamed and irritated, but it could actually be the size of the nerve bundle. So if that nerve bundle is too big, we need to do something to reduce the size of that nerve bundle. Just myofascial releasing, doing toe spacers, using a met pad, wider toe box shoes, that might not help all patients. Neuromas are very, very finicky. For some of them, it could be the size. So we need to look at different techniques to sclerose or shrink the size of the neuroma or the nerve bundle itself. That is where, like I said, I would turn to alcohol injections. Now, if the alcohol injections are not something that is really open to the patient, or they don't want to come into the office once a week for 10 weeks, I get it. This is where you would look at radiofrequency ablation. There's also a cryoablation. Personally, I like radiofrequency. I find the efficacy is a little bit higher. And you would essentially put a needle or a prong into the neuroma, and then you would send a pulse of the radiofrequency through into the neuroma, and you get a rapid shrinking or sclerosing of it. Now, that rapid sclerosing of the neuroma oftentimes has a very high success rate. It reduces the size, which reduces the irritation, and then through consistency of met pads, wide toe boxes, toe spacers, and SMR, the patient becomes asymptomatic. Now, if that fails, this is where then you would be looking maybe at surgery. I typically will refer before surgery to do stem cells, because the stem cells are fibrinolytic, which means they're going to break up some of that scar tissue. So I will typically do that as my next option. And then surgery is always the last resort. Now, when you do an excision of a neuroma, you can think of it kind of like a little spider, where you have all of these little branches coming out of that neuroma. And if you don't get every single one of those tiny little nerve branches, you can get a stump neuroma. So if you've ever heard of stump neuromas, that is essentially saying that they still present with the same symptoms because one of those little pieces of that neuroma was left inadvertently during surgery and through the dissection, and now they're still symptomatic. Stump neuromas, or persistent neuroma pain after a surgical excision, is extremely frustrating. For that, I oftentimes go back to stem cells to try to get some fibrinolytic benefit for these patients. But this is where I try to exhaust everything before I do surgery. So again, to give a little bit of perspective, you got someone, you think maybe it's a neuroma, classic neuroma pain. As they shift forward to take a step, boom, they get a sharp pain. Or they say, when I run, my third and my fourth digit go numb. That's a neuroma. When I do the elliptical, when I exercise, when I shift forward, it feels like there's a wrinkle in my sock. Classic neuroma pain. Neuromas are not just between the third and the fourth. That's a Morton's, but there's other neuromas. It could be any of the metatarsals. The pain is typically, if this is my foot, we're thinking, here's the met head. The pain is typically not there. I will actually have patients say it's more like right there is where the pain will be. You could palpate and see if it's painful, but oftentimes they'll do a compression. And when you compress the foot, this is called a Mulder's test. You're listening or you're feeling for a click or a popping, and you can actually feel the neuroma pop between the metatarsal heads. That is where you then want to start thinking about, how do you want to address this? Start conservatively. If you're not getting any benefit, then see a podiatrist, consider injections. If you're not getting any success, use surgery as the last resort. Now, I will add, just as a small personal expert opinion on this, is I do not find that in symptomatic, triggered, elevated neuromas that are giving a signal to the patient every time they take a step, it's at a 10 out of 10 for these patients. I do not believe in physical therapy. I 100% believe in injections, and it's just the nature of the injury. You got to get that neuroma to calm down, and then you can start to strengthen the foot, mobilize the foot. What's happening between the foot and the core? What's happening in their movement patterns? What's happening in their global patterns before you start going down that physical therapy global integrated perspective? We've got to get the tissue quiescent. So that is where, just think in the back of your mind, maybe this patient needs to have some injections, and then we go back to me where I'm doing my movement therapy, my physical therapy, and my integrated approach to looking at the body. Okay, I hope that this helps put a little bit of perspective on neuromas. Neuromas are a very unique injury. They're very little instigators that are quite stubborn, kind of like post-tib tendinitis and Achilles tendinitis. So please do continue to follow Dr. Emily DPM to learn more about different foot injuries. And if you have any foot injuries that you would love to have an IG Live about, please just inbox me. I love to look or have ideas of what to speak about next. Thank you guys so much.